Hello, everybody, and welcome to this PhysiQuip webinar, PhysiQuip Academy webinar, the essential role of diagnostic ultrasound in podiatry. To those who are joining live this evening, welcome. Thanks for taking some time out of your day or your evening. Hopefully, you might have a glass of wine and listen to some stuff on ultrasound. For those watching back the recording, again, welcome to you guys as well, and hope you enjoy the content coming forward. Just a bit of housekeeping stuff in terms of going forward. For those that are live on the session, there's the opportunity to ask some questions after Zoe's presentation. There's a Q&A tab at the bottom of your screen. If you pop it into there, any comments you want to make, you've got the chat function as well, and we'll get some conversation flowing on that. In terms of the format of the session, Zoe's going to have a little presentation to go through to kind of set the scene around what we're talking about this evening, and then we'll go into Q&A. We have got some pre-submitted questions, but we're also going to go on the fly as well. So anything you want to ask, slap it in, I'll get it asked. For those people watching back on the recording, if you've got any questions off the back of it, just email us at info@physiquip.com and we can get the question answered as well. So without much further chatting, I'm going to hand over to Zoe to introduce yourself and we can kind of get cracking from there. Zoe.
Brilliant. Thank you so much, Dom and Katie and Andy and everyone who's involved in PhysiQuip. It's been really great to meet you guys over the past 3 months and an absolute pleasure to speak about this subject, which I think is definitely raising some eyebrows, certainly in podiatry. But I'm basically just going to talk to you about how amazing it is, maybe a little bit about the equipment that I use day to day, and then also kind of the journey that has unfolded because it's been quite eventful for myself. So we will cover some areas around training, competency. I'm not going to be going too much into the new guidelines, but so there are some new guidelines that have come about from the Royal College. So I think it's important that obviously we skirt over that, but I'm certainly not going to be going into that as such. But I will raise it because it's an important part of this presentation. So very much in the Boris Johnson way, we're going to be doing next slide, please, via Dom. So if we could just move on to the slide. So a little bit about me, a little bit about my practice. I kind of think it's important that you understand, what I do day to day. So I'm an MSK podiatrist, but I am owner and founder of ZW Clinics, which was formed in 2017 by myself, myself, and I. And then it's kind of developed into a multifaceted sort of practice now. My background really was obviously my undergraduate podiatry, which I studied at Salford, and then I did my MSc in theory of podiatric surgery, and I've got a background really surrounding this area of podiatry. And then I've recently completed my PG cert in medical ultrasound up in Glasgow. And yeah, so just on to the next slide, please. So this is kind of my setup, really. I work with everyone, including podiatrists, physiotherapists. We have a podiatric surgeon who comes in as well, does consultations and interventions. I run courses on prescribing an ankle foot orthotic, which is the device you can see in the bottom right of this slide. So we train podiatrists on prescribing this device, and we do 3D gait, we do nail surgery, but it's a little bit of a biomechanics focus, really. So my clinic room is that second image in. So we've got obviously treadmill, pressure plate, ultrasound in the corner there. So it's kind of a bit of a multifaceted practice, and that was kind of the goal. My colleague on the bottom left, I thought if there's any physiotherapists joining, I do MDT clinics with Gemma Donald, who's owner of Absolute Physio. So we've really integrated a multidisciplinary team here. Next slide, please. So a little bit about the content. I've already mentioned kind of what I'm going to cover, but I'm going to go a little bit into my journey because it's probably been a bit different to what yours might look like. Some of the challenges because really this process can be quite challenging. And I think it's really important that we're upfront about that so that you know what to expect. Then we're going to talk about how amazing ultrasound is in podiatric practice and how it's such a great tool when looking at the foot and ankle diagnosis, management, the lot. Like, it's just great. Some case examples, so some examples of what I've seen clinically, and then yeah, questions open to the floor, really. Next slide, please. So my journey's been a little bit mishmash. It's kind of formed from one thing into another and then arrived at the destination I'm at now, which might not be the final one. So the first thing that I did was I actually bought an ultrasound machine. So I had an ultrasound machine in my practice. I wasn't using it for diagnosis. I was using it purely for practice to expose my self on how it works, and it just really gained, I really gained a fascination with it. But probably about a week after I got the machine, I actually was on this podiatry short course. So it kind of all came at once. And Bournemouth do a podiatry short course, which is run over 2 days. It's CASE accredited. So CASE is basically an organisation that oversees education surrounding ultrasound. So the Royal College recommend a CASE accredited course. So whether that is a short course, usually with mentorship and logbook, as well as an examination, it kind of forms the basis of the baseline of education that's required. Now, partway through this course, bear in mind, I'd been doing this for 18 months. I had a mentor coming in every week or every couple of weeks. I was building up my portfolio. I heard on the grapevine that a PG cert was actually going to be coming in, and that was going to be the expected mode of education. And I was like, all right, okay. So then I spoke to 2 or 3 people who were already on this route, but I was quite early on that route, like, right, if this is what's needed, that's what I'm going to go and do. And also I did have some difficulties organising my, examination, and Bournemouth's like 5.5 hours from where I live. And so, yeah, I kind of thought, you know what, maybe I can transfer some of my logbook hours over to the PG cert. And when I contacted the university at Glasgow, they allowed me to do that. Not all of them, but some of them. So it wasn't too bad making that transition. And for me, really, it just gave me more exposure to performing ultrasound under mentorship. So I learned more. My probe skills, obviously improved because I got more exposure. And then I started the PG cert in 2023, and that was run over 18 months for myself. And that was a combination of physics exams, you had examinations surrounding ergonomics and all the kind of boring stuff like your setup when you scan in, what is your clinical environment, what do you need, how do we store images, how do we write reports, and all things like that. So it's quite an undertaking because you've also got to arrange your mentor. Your mentor has got to have a specific level of qualification as well. They've got to be agreed by the university before you're allowed to obviously have them accepted as part of your PG cert. So I was very lucky. I had a wonderful mentor who's a physiotherapist, probably the best physio I've ever worked with on foot and ankle anatomy. I mean, his anatomy was as good as a foot and ankle surgeon. Like his understanding of the anatomy was just, over and above. So I was really lucky, and he selflessly gave a lot of time. But also you've got to pay for the time. So, the mentor has got to be paid appropriately for the time and expertise that they give you. So he goes up and down the country, mentoring people all over, and that is a part of the process, and that has got to be set in stone as part of your educational journey. It's then implementing it into clinical practice. So then how does my day-to-day look? What can I say I do? What, how do I kind of integrate it into my into my clinical environment? What do I call myself? Sonographer's not a protected title, but with the new guidance from the Royal College, it's an ultrasound practitioner. That's kind of the term that is supposed to be kind of adopted moving forwards. But again, I'd advise you to go and read over that document and speak to the college. It's not really for me to kind of go into. And then ultimately, my next goal is image guided applications. So I already do injection therapy. I've got my steroid injection qualification, but I'd like to do a guided course before I start, setting this up as a service. Yeah, next slide, please. So yeah, we've already kind of skirted over mentorship and how that is probably, on a national basis, that's probably one of the most difficult aspects of the training, but it's the most important. And you get so much out of it working with somebody that's got those expertise. It's a fantastic process and it's really fun to be the student. And you've kind of got to get back into a student mindset, which I also think is a wonderful mindset for learning. It's just accepting that guidance and kind of being vulnerable again, but you've got to have an accepted level of that when you're learning, or you won't learn as much. Studying, obviously, you get home from work, you finish your clinic, you're sat at the kitchen table like I am now, and you're studying. Do I think the PG cert is long enough, intensive enough to cover all aspects of what you need to know and what you'll learn over the years? Absolutely not. But it sets a baseline for you to, safely practice. Building portfolio, so you'll build up your list of scans, what you've scanned, what location, what you've found, what does your report look like? Were you assisted or unassisted? So that's kind of an example of what the portfolio looks like. You'll have exams, you'll have assignments, and there's definitely this thing of, I'm never going to get there, and I think there's definitely a part of it where you think, I'm just not going to get there. Like, I don't know what that is. That should look better than it does. I don't know. And then eventually you just reach this, well, it's like unconscious competency, isn't it? It's like anything that you learn. You're like, oh, I get it now. And that's a part of the process. There's frustration, and you try not to be frustrated when you're imaging patients and, things are not as they look, but that's what your mentor is for. And when you find the right person to do that, then those frustrations become goals and achievements. So next slide, please. So what do we do in terms of imaging in podiatric practice? Well, I've included three. These are the three main ones that I use, but obviously there are other applications, but I think these are probably the most common. So x-rays, obviously, if we're looking at bone pathology, if we're considering arthritis, for example, it's still gold standard first line as an imaging modality. It is used more in surgical practice. So weight-bearing x-rays are used for surgical planning. But they are particularly good if you're wanting to look at the bony architecture in isolation. You can't really see a lot else, but the bony architecture, I'm sure you'll agree, when you look at the MRI and you look at the x-ray, that's much clearer in the x-ray if you're kind of looking at bony integrity in isolation. And then MRI kind of covers all bases. And sometimes we might do an ultrasound and we might need to refer on for an MRI. So if we've got any concerns about intramedullary lesions, so inside the bone, in that, through the cortex, and inside the bone, then that's certainly an investigation that we would consider. We also consider it if we're in any doubt about lesions that we might need to look in a larger field of view. So if we're concerned about any malignancy, or if we just want an overall viewpoint of the entire foot and ankle. I mean, many of you will see these, and you can just swipe through an MRI by rolling your mouse. If you're using like a PACS online system. We use a service known as scan.com, which is essentially a company that's set up with radiology departments all across the UK. And essentially, you can put the patient's address in, they will select a site, usually a trailer that they go into, have an MRI, you get the results within 2 weeks. So, this is a really good method of obtaining this type of image. And then ultrasound, obviously, number one in my opinion, because you can kind of look at everything. You can't see inside the joint, you can't see inside the bone, but you can see the surface of those landmarks where it might be enough information for you to warrant diagnosis. It's certainly considered gold standard in tendon assessment, and partly because we can dynamically stress the tendon, we can dynamically stress a ligament, we can look to see if there's active inflammation. So if you've referred a patient for an MRI, particularly through the health service, that might be 6 months. Yeah, and then how long is it before we're getting the results? Is it still relevant? The point of ultrasound is that it's point of care. And that is so powerful. And you can look at so many structures. I know Kathy Bowen is doing a lot of research at the moment surrounding the use of ultrasound in podiatric practice and seeing early changes that we wouldn't necessarily see on X-ray when considering degenerative joint changes. So yeah, it's just awesome, really. Next slide, please. So in podiatric practice, what are the type of things we're looking at? Well, we know the foot and ankle is very superficial, so we can look at most things, which is really quite remarkable. If we want to look inside the subtalar joint, it's not great. If we want to look inside the ankle, it's not great, yeah? But majority of the other areas, midfoot arthritis, it's fantastic for looking at ATFL, AITFL, CFL, so all those lateral ankle structures, very superficial. Once you've obviously understand the anatomy, it's really easy to stress test them as well. But here's a good example. So this image in the middle is the fifth metatarsal. So we've got the asymptomatic image on the left. We've done a dual image on the right. And this shows a fracture of the fifth metatarsal head. And this is a patient who came in for core podiatry treatment, had swelling, redness, heat, and some degree of trauma to the foot. Typical farmer in our neck of the woods, doesn't want to go to A&E, just like, I'll crack on, get my wellies on, I'll be fine. And then obviously we diagnosed this. We did send him for an X-ray as well. So we do just, particularly because we still know that X-ray is gold standard for fractures. And looking to see the extent of that fracture. Because again, you'll see that below the screen it's black, and that's because the beams won't penetrate through the cortex. So we can't see how far that fracture is distributed through the met head. This is me doing basically an image-guided steroid injection for the midfoot under the provision of a colleague of mine. So, I think it just kind of showcases some of the variability that we might see in podiatric practice. Yeah, next slide, please. So we're going to go into some case studies. Sorry, they're wordy. Don't look at the words, just look at the pictures. So what we've got here essentially is a patient who we see probably 5, 6, 8 times a week present with heel pain that worsens first step in the morning, eases with a bit of activity, worsens towards the end of the day, presents with a 4-month history in this case, doesn't know what it is in agony, can't go to the gym, can't run, trying to run to lose weight, overweight, heel pain. Like just this typical kind of presentation that we see. Interestingly, this patient, not the image you just saw, but he had previously had a fifth met fracture the year before on the same foot. So a little bit of history there. Type 1 diabetic, insulin managed. And this is a really lovely image which shows you the measurements that I took in a long axis view. So the white bit with the black underneath is the calcaneus, and then the thickened plantar fascia is that structure that you can see where I've done the markers. So from the bone to the top of that thickening, it measures 7.95 millimeters, which normal plantar fascia, well, we've got and this is the other benefit of ultrasound, we can measure the contralateral side, which is 3.98 textbook. 4 millimeters is what it should be at this level. So you can see the changes that we can identify on ultrasound are so clear, and you're not going to get this delineation of structure with an MRI. It just doesn't look this clear. So, a really good example where plantar fasciopathy, my go-to is an ultrasound if I'm predicting that that's the case. We can assess for tears, we can assess for active inflammation. If we've got enthesopathy, where we've got inflammation of the attachment, we might consider inflammatory markers being checked. Yeah, next slide, please. So moving on to something a little bit more interesting. So this is my pride and joy of a pathology involving the posterior tibial tendon. So we're actually looking at a patient here who started to notice some changes with his feet over probably a 12 to 18 month period. And he's always had quite a flat foot, so a pes planus foot, low arch, periodic ankle pain, a little bit of calf inflexibility, family history. And then he developed this swelling and pain on the medial aspect of the midfoot following his completion of the London Marathon. So what we've got here is an insertional posterior tibial tendon issue. His foot is actually the far left. You can see the little gap between so this is supposed to be one continuous bone. If you look at the image on the far right, you can see one continuous bone. So that's what it's supposed to look like, although this is enlarged on the far right. So this is what we call a type 3 accessory navicular. But this one here, where we see the little gap, almost looks like a fracture, but it's what we call a synchondrosis. So it's where you get a slight little bit of cartilaginous junction, if you will, between the accessory and the navicular. And so, getting pain. But I mean, it's just a prime example of normal versus, abnormal. The image in the middle, you can see a nice healthy tib post and FDL close by as well. So it looks flat, almost oval, a bit like an eye. And then if you look at the dual image to the right, you see all the orange flecks. And then you can see that it's not oval, it's quite round. So that's an example of a inflamed posterior tibial tendon, and just a comparison between one side and the other. Yeah, next slide, please. So then we move into something a little bit more obscure. 47-year-old female presents with 6-month history of lateral border foot pain. It's unremitting. She's in agony basically all the time whenever she's on the foot. She rated the pain as a 9 out of 10. We interestingly did a point of care ultrasound because I'd not seen her before. But we then found out at the end of the appointment that she did have some x-rays that came back inconclusive from the GP. And I said, right, well, let's request the x-ray. Lo and behold, this beautiful accessory is perfectly evident around the lateral aspect of the cuboid. You can see it clear as day. Now, what she did have was some tendinopathy of peroneus longus. So, we treated her with shockwave really successfully. Another fantastic adjunct to, you can monitor tendon thickness and response to treatment. I basically do like image guided shockwave. So we use the ultrasound to guide the use of the shockwave and where we place it, because I think that's also really important in terms of getting your outcomes, is knowing where to put the shockwave. So that's a nice example of something a little bit obscure, but again, you can see, I mean, look at it, 7.56 millimeters on the outside of the foot, like it's quite a large accessory, and then, ultrasound to confirm that as well. Next slide, please. So my final case study for you, nearly finished, was a tib-ant rupture. I mean, when do you ever see this? Like literally never. The patient didn't want to go to A&E because she kind of knew me, she knew my clinic, and the skill set that we've got. So she actually preferred, we're getting more acute cases coming in. some of our clinics are becoming like little A&E centres or little GP practices because we're managing all manner of things. And as podiatrists, we're very lucky that we've got a massive toolbox to do that. So this was an acute onset snap, essentially in the medial aspect of the ankle, kind of anterior ankle, but heading into the midfoot where we know this tendon inserts. Image at the top, you'll see the gross changes within where the tendon sheath would be. So all the black here around the tendon's actually the little bit in the middle, the almost like white tube in the middle. And then the black on either side of it is the tenosynovitis that's occurred as a result of the rupture. The end of the tendon in the bottom image, kind of, I don't know if you can kind of see that, but you can actually see the tip. Yeah. A bit lower down. So that's the actual tip of the tendon where it's snapped. And then if you could just play the video, please, Dom.
Sure.
Thank you. So you'll see, so this is me basically plantar flexing and dorsiflexing the foot, and you can see that that tendon is chasing up into the proximal aspect of the patient's body, which it shouldn't be doing. So that's an example of how we can use ultrasound in an acute setting. Just go on to the, maybe play that again. Yeah, that's quite
Yeah,
cool.
sure, can you?
You see it chase, bye. Just chases back up that tendon sheath. And then if we go just on to the next slide, so this is just like perfect use of ultrasound. I'll just show you the next slide because we can actually track the patient's response to rehab. So this is the repaired tendon. So I actually put this patient in a vacoped, but I did it the opposite way around. So we had her in basically in dorsiflexion so that the tendon could heal. It was under the provision of podiatric surgery and physio and me. So I actually got them all in one room together. I planned to do a write-up on this because it's such a fascinating case. She'd also had an antibiotic which predisposed the tendon to rupture. So that was just, yeah. I mean, she jumped out in the road to get the dog and then just went snap. So very unusual. But then if we just play that video, please. So this is, you can see the synchronous movement. So you can see that little end isn't chasing up. It's not perfect. We're now shockwaving this lady, and it's the recovery, the response, because she's basically got a nodule now where it's healed. And because the gap wasn't bigger than 2.5 centimeters, she didn't have surgery. And I got orthopedics involved and podiatric surgery. And they just said, look, if you can rehab it, that's going to be potentially a better solution for her. So that's what we did. We're now sort of shockwaving the nodule to try and kind of break down a bit of that scar tissue. And the results have been great. She had 2 sessions, 2 weeks apart. We've got 2 more to go. Yeah, just. I mean, that is ultrasound. Like, if that doesn't make you want to do ultrasound, I don't know what does really. Okay, and then next slide, please.
Which should be going? Oh, I played the video again.
It just wants you to play
There
it,
we
doesn't it?
go.
So, closing remarks. It is a great journey. It's the best thing I've ever done in my career. It's a wonderful skill set. Set aside appropriate time and patience because that is probably the one thing that I would tell myself if I was doing it again. Ensure that your training meets the standards for insurance, and there is some new guidance that you can go ahead and look at. I can certainly send you a link to that, guys, if you wanted to add it on to the notes or anything. Mentorship's probably the hardest part, getting somebody to mentor you. And basically, once we've qualified, after 2 years of practice, we can mentor anyone. So the great thing is that there's more people like me coming through, which means there's more people to mentor you. Enjoy the process. I say this with every part of what we do as clinicians because there's ups and downs, but ultimately it's usually quite fun, for me anyway. Thanks for listening, and I welcome any questions.
No, thank you very much. So I appreciate obviously going through, and and like I say, I hope that it gives people a bit of an insight into what diagnostic ultrasound or just imaging generally can bring to the practice. Um, I think just to add on to what you were saying about in terms of that learning process, it is difficult. Obviously, I've been working around this area for 5, 6 years now. Not as a scanner, I dabble a little bit with it, but it's more just from a demo perspective. I just drive the machines mainly. But I don't think I've met anybody yet that's regretted learning how to do it. I'm sure there's been moments where they have regretted thinking, "What the hell have I done?" But you'll have good days and bad days, and I don't know if that's the same experience for you, for anybody that's learned it. Is like once you get to that, like you said, that unconscious level of competency for you, has it just opened up another level of your clinical ability?
Yeah, I mean, like if I could explode, I would. Like I'm that passionate about like what it's done.
Yeah,
It's transformed how I look at patients. It's transformed what my previous thoughts were about anatomy and where anatomy was, and how small or how big anatomy is. I always encourage anybody to go and do it cadaverically as well. So get yourself in a cadaver lab and learn that way.
yeah,
But I think what's really important is that it takes a long time. And the thing that keeps you fascinated is the fact that you can put it on your arm and move your fingers. Like if you ever just like, oh my
yeah,
God, like I'm losing the will to live, just put the probe on your wrist and just move your fingers and you're like, this is why I'm doing it. This is
yeah,
why. Because again, a really superficial area, but the avenues that it's opened up from a learning perspective, a diagnostic perspective, and how we manage patients, um, is the reason that I think that my outcomes have improved and yeah,
yeah.
everything. Yeah.
Well, we've got some questions. I think we could both wax lyrical about the benefits of diagnostic ultrasound. I think you covered some of the challenges in there. In terms of finding that mentor, you mentioned that you got quite fortunate with finding that mentor. Have you got any advice? One of the questions was any advice on how to find a mentor? That is something we come up. We're trying to figure out a solution at PhysiQuip, but it would be good to get your sort of thoughts on how to broach it, really.
The thing is, a mentor has got to be, they're essentially they're putting the probe that they usually have in their hand in your hand and
Mm,
your responsibility.
yeah,
Uh, and, unfortunately, what's changed now is if you're doing a PG cert, they're saying you have to have a PG cert mentor. Whereas my mentor was one of the people that qualified kind of before PG certs were about. And
yeah,
he did his with Smug, I believe, in London. And basically, it was still a logbook, it was still a case accredited. So that's still fine. But now they're saying that somebody with a PG cert has to mentor you and they have to have had
right,
2 years experience. Now, for
yeah.
me, I have about 5 years experience because I did not the wrong route, but I did the route that is
More
still
convoluted
accepted.
route, less direct.
Yeah, it was the one that was available at the time,
Yeah,
and
yeah,
then the PG cert came in and it was all just a bit crossover, so I knew there's not a chance in hell that I'm waiting and seeing if this PG cert is the thing. I'm just going to go and do it. So I literally
yeah,
left an institution which I've never done before without completing it, almost
yeah,
completing it. I was literally like booking my exam. But being honest, like there was some issues with that institution and somebody had left and it was all a bit of a mess at the time. So that's another reason that I
yeah.
left. But it is hard. But I think, if you find,
Worth it in the end, like if you stick to it.
oh, like, yeah, I mean, it's not that. But I think advice to people is probably to come and shadow somebody in clinic first.
Mm,
And then that might open up a door for a mentorship. Mentorship's not just about getting a qualification, it's about having a relationship with the person that is going to be
yeah,
teaching, and if things don't align that way, that's going to be difficult. It's a very
I'm
close, you know.
I'm glad you said relationship because obviously, with Andy, who that's where the conversations come from, and that conversation, our connection with you's come from Nick Knight, and then we're speaking to Darren Fitzpatrick and Steve Miller. And I think that the relationship aspect, the network side of things, I think if people are looking for mentors, I think don't be shy in reaching out to people via LinkedIn or dropping emails to people. And I mean, obviously we work on the sales side of things. I'm a big believer, like a 2-year-old. It's just like if you don't ask the question, the answer is always going to be no if you don't ask. And what's the worst they're going to say is no, I'm
I
not
think it's
available.
really.
So I think it's like if you see people that are
Mhm.
scanning and you're looking for that mentor, it's just like you say, build that relationship with somebody, maybe shadow them, like you say, and then
Mm.
I think it's difficult. I mean, like I say, we're looking for solutions to try and make it easier, but I think until a solution is there that's beneficial for the mentor and the mentee, is the best thing probably is like you say, that trying to build a relationship and a bit of a network, really.
I think being truthfully honest, it is about that. And people know people. I know that my mentor will go around parts of the UK to go and help people, and he's a
Mhm.
fantastic mentor. There's also a lot of radiologists who are open to having you in. People like myself, Alistair Oxbury, Sean Savage, Nick, no, Nick's not doing it yet, but like, and podiatric surgery departments. But I think the mentoring thing is hard and it's a case by case basis.
Yeah,
Um,
yeah, yeah.
but I've started running a few webinars with Sean Savage, and I
Mhm.
kind of set this thing up last year, or we did, called Diagnostic Ultrasound in Podiatry. So it's a group that I'm trying to form where there's going to be a big population of people in podiatry, and hopefully that's going to then raise more opportunities for mentors to connect with students. So just,
Sure.
kind of watch what I'm going to be up to over the next year, because I think we've got to bring those people together, and that's how those mentoring opportunities will come about.
Sure. Right, we'll rattle through some questions
Yeah.
to get through. So relatively quick fire, if we can. First one that's come through from Patricia on the webinar is, what course would you recommend for ultrasound guided injections if they're already competent in injections?
I'm probably not the person to ask actually, because Stuart, you need to speak to Stuart Wildman. Stuart
Yep.
Wildman's told me that there is a new module that's coming out this year, I believe at Brunel, which is going to be the first image guided ultrasound course for podiatrists. So I would urge you to contact Stuart Wildman. Um, and there are a couple of cadaveric courses as well that are around, but
Yeah.
the competency recommendation for me would be to get that module.
Yeah. I think if there's until that's there, I mean, like I said, there's some CAD lab stuff that you can do. We were speaking about it to somebody today. Good thing about CAD lab, they don't twitch, so you can practice and you can do
Yeah.
it as many times you want. If they do twitch, then you'll be out of that room quicker than you can say injection.
Yeah.
Um, so, but no, they're good. Right, in terms of suitable diagnostic ultrasound machine, not necessarily brands, but maybe type, like handheld, portable, cart. Like, what's your feedback on a suitable machine?
So I've tried all. I think they're all improving all the time.
Hmm.
The best two machines that I've ever had in my hands would be a laptop based machine. So you guys have brought me the Alpinion i9, I
Yeah.
believe. There's a potential to get two probes with that, which I'm probably going to be getting next. Um, just because you can look at smaller anatomy with the
Yeah.
higher frequency probe, and then you've got the bigger probe for your general stuff and muscle belly and things like that. So I really like a laptop with a little trolley, but I've used a cart-based system when I was training, like
Yeah.
amazing, but massive and unnecessary if you're not looking inside stomachs. Um, there's also like your handheld. Personally, I don't think that they are intricate enough if you're going to be doing, diagnostic um services with that. It might be okay
Yeah.
if it's guided, but for delineation of structures, I think for me the laptop is the best. The only other one is I have a Sonoscape X3 at the moment, which I've loved, but I need to upgrade. Um, but they're the two on the market is your Alpinion, which I believe is the best laptop, like image quality machine on the market. But there's also what's the other brand? Um,
If you don't want to say it, that's fine. We can stick at the
no, because I
Alpinion
think it's fair to say
i9.
it. We're not
It's,
here to sell equipment,
there's
but
Konica Minolta, GE, there's
GE,
GE. Yeah,
yeah. But actually, the image quality on the i9, and a lot of my colleagues have used the i9. They're saying that that's currently the
cool.
best
But in
image.
terms of like a category for those wanting to learn, just like kind of go for a laptop one, you're probably going to be about right in
Yeah,
a
you don't
region in
want to be
there.
getting something that's cheaper and doesn't fulfill what you need. So
Yeah,
my
you'll be
advice
buying
would
again.
be if you can afford to do it, get the better machine
Yeah.
from the get-go
Or
because you
even wait. Did you think it's even just like if you just price it up and then you can save a little bit, or and wait until you can get a laptop, something like that?
yeah, but the advice to me has always been if you can afford to get a better laptop-based machine
Yeah,
around about the 20,000 upward mark,
yeah,
um, that's where you should position yourself if you can. The
yeah,
cheaper machines, you're not going to get the image quality and you're not going to get some of the features like power Doppler, which is really important. So I think, you've got to be looking around at least 15 upwards, just to give you an idea around cost.
yeah. Great. Right, last couple questions. In terms of, in fact, actually, I've got one before you mentioned Doppler. So a little one before we have spoke about in podiatry. So you're scanning obviously musculoskeletally. Do you see an application of diagnostic ultrasound for those who have vascular deficiency when you're looking at diabetic foot ulcers and things like that? Is there application there as well for those who see both ends or even more, they see more of that kind of thing?
Yeah, like again, not my field
Yeah,
of expertise, but I know that colleagues like Emily Howarth, like all doing amazing things with vascular applications for ultrasound, which I think is like hugely exciting. So
yeah,
absolutely, yeah.
great. And then yeah, right. So last couple things is how do you? It might be a little bit of a long answer, but if we can keep it nice and short, just look for the time. How do you integrate ultrasound into your practice?
Oh, so a really good question. Hopefully it's not too long. So when my mentor was coming in, we used to have imaging days. So they were basically like MSK consultations. They'd come in, give us a history, we'd do a clinical assessment. We would then ascertain before they came in whether or not this might be something that we would potentially use diagnostic ultrasound for. Um, and we'd do it as part of the MSK assessment. That's what I still do.
Yeah,
Because technically, I don't believe we're supposed to have a standalone imaging service. So for me, I allocate an hour and a half, sometimes longer, sometimes less. And I perform my ultrasound examination within the same appointment as I would do my MSK consultation. So
yeah.
it's an adjunct to
If
my,
it's needed, if the ultrasound's needed,
yeah, for
you
sure.
just yeah,
Sometimes depending on the triaging process, if they're going
yeah.
to need it. But yeah.
And just to bolt on to that as well is that in terms of its purpose of use, kind of load the question a little bit, but are you using it as a diagnostic tool or a rule in, rule out tool based off of your subjective objective assessment?
Both.
Both. Cool. Yeah, great. That's fine. And then last question is best bit of advice that you can give for someone who is looking to learn how to do diagnostic ultrasound.
As in advice about training or just advice in
I
general?
think what's the one thing I think more so I think when somebody's actually in the process, let's say they've bought the machine, they've been on the courses, they're in the thick of I'm in that learning side of things.
Yeah.
What's the best bit of advice that you could give somebody when they're in that?
Be kind to yourself and don't put
Yeah,
pressure on yourself too much because I have made both of those errors and it's not a great environment for learning. This is not something you're going to learn overnight. I'm still learning. My mentor's still learning. The best radiologist in the world is still learning. So I think the best bit of advice is be kind to yourself. If you're scanning and you get to the point where you're starting to move up and down a tendon, or you're starting to be a bit more confident with it, still be really slow with your movements. Make sure that you've got good contact. Just there's ways, that you will get faster, but even when you start to get that little bit more competency, just go nice and slow.
Right. No, I think that's perfect to wrap up on that, Zoe. I appreciate your time this evening. For those who have joined us as well, do appreciate you sticking with us, and hope you've taken something out of the session. And for those watching it back as well, thank you for taking the time to sit and listen to us as well. So just to wrap up, I'm hoping that's not the last slide. Is there one more slide on that? No, there isn't. That's okay. So if you've got, like I mentioned at the start, if you've got any questions, any queries about this content, you want to learn more about diagnostic ultrasound, the learning pathways, contact us at PhysiQuip, info@physiquip.com, and we can try and get those questions answered. In terms of the educational side of things, the PhysiQuip Academy is developing our own ultrasound education provision in the form of half-day workshops. And we've seen this little gap in the market of trying to find accessible and affordable diagnostic ultrasound education that's open to everybody, regardless of where you are on your learning spectrum. So in terms of where we are at, I mean, these courses are 100, 125 quid, half a day on a specific joint. So in terms of upcoming April 3rd, April 4th, foot and ankle, we've got that on in Manchester. At the end of January and on the 30th of Jan, in the afternoon, we have lower limbs, which will be covering foot and ankle as well. That's at Hampden Park. And then in London, I've lied, sorry. On the 13th of June in Manchester, we have an introduction to diagnostic ultrasound. Now, on the stuff that we've already done, we've had people that have got 10, 15 years worth of experience. We've got people that are brand spanking new to it. And I just think it's a nice way that you can have multiple abilities and experiences integrating. And you say about bringing people together, Zoe, it's about that. We've had a sports therapist partnered with a sports medicine consultant, one with absolutely zero ultrasound experience, one with 25 years worth of experience. It's brilliant
Great,
to watch that
great.
that unfold and how they interacted. It was fantastic. So yeah, that's what we're trying to do. They're not like sort of official courses, but in terms of what they'll do, they give you plenty of hands-on practice and in a really comfortable environment where you can challenge and ask the questions and really kind of get to grips with the technology. As you mentioned, we do Shockwave as well. So we've got Shockwave on April the 3rd as well. So, and a couple more. But you can go to the Academy website for the other more webinars, and our website, physiquip.com/events, and you'll see all of our courses in there as well. And after this, we'll send out a survey. So if anybody has any ideas, anything else that you'd like to hear about, let us know. Please, we really want to put on stuff that you guys want to hear about. You are all on the front line. Same from you, Zoe. It's like you're on the front line. You know what you're dealing with day to day. Advise us. We've got this educational platform. We want to be able to deliver the stuff that you guys want to learn about. So that feedback would be great. But in the meantime, it's a Tuesday evening. Is it Tuesday evening? Yes, it's Tuesday evening. I'm losing track of days.
Yes.
I think we'll clock off. What do you reckon, Zoe?
Yeah, sounds good. Thanks, guys.
Fantastic.
Thanks for
Thank you
listening.
very much again for your time. And yeah, I'm sure we'll see you on the next one.
Thank you.
All right. Bye bye.